time now for session 3, and the this session is we're going to hear from a number of larger organisations where they're both government and professional organisations, where we're going to get some background and perhaps some answers to some of the things that have been raised by some of the early speakers and participants as well. So it gives me great pleasure to introduce our first speaker, who is Shelly Sydney, whom I work with at Airways New Zealand. So Shelly, you're on. She's the Manager of Health and Safety at Airways.
Okay, just while that's coming up, I just thought it'd be a good idea just to tell you a little bit about Airways Corporation. We're a state-owned enterprise. Safety is at the heart of everything we do. We're responsible for air traffic services for 30 million square metres of airspace, so quite a large area. We're located across 2 radar centres across New Zealand, 19 towers, and we look after nearly around 1 million air traffic movements every year. So we also provide and maintain air navigation equipment and communication systems. We have 840 employees. Almost half of those are air traffic controllers or flight information officers. We also have our technicians and our networks and systems engineers. We have our corporate support services and our safety and assurance team, which is where I sit. And our global commercial business, which does a lot of work around the world providing training services. And we also have a training college. So if you want to just pop to the next slide, please. So I just thought what we would do is just go over a couple of slides around our COVID response, just to kind of set the scene. We were really lucky to have Dr. Rob involved with us very early, and we had a very comprehensive pandemic management plan. So as you can see in January in 2020, when we were starting to become aware of this happening, we very quickly were able to sort of activate and we started to get kits out, PPE out to our people. We started looking at where our travellers were around the world and getting them back home, and also cancelling essential travel. Dr. Rob was able to provide a really good update to our executive team, which is always a good place to start, because you're activating sort of your crisis management team. And we're also able to start to get some early communications out to our people and train our pandemic managers, which was quite a new thing. Next slide, please. And so as this next slide comes up, you'll see that as the government initiated that early first sort of couple of weeks of isolation, our focus was on supporting our people working from home. So really quickly being able to get out information about working from home, getting desk setups, how to support people in those kind of environments. So we did a lot of that, and then as we went into that sort of that 4-week sort of isolation period, my team really activated and started to kick off developing resources. So, not just for working from home, we obviously had a whole group of our people who still came to work as essential workers. So, how did they clean their workstation? There were all sorts of things that we put together for them. So even down to how do we carry out random drug and alcohol testing? Well, we had half of our people at home and half at work. It was still important. But also, how did we give information for people who might have been stressed or feeling a bit out of the loop, couldn't work from home properly, had children, there were all sorts of things, and I'm sure you talked about a lot about this in earlier presentations as well. Next slide, please. To make, I guess, an effective, we already have an executive crisis management group, so we activated them, and they were responsible for the decision making. I sat in the national pandemic manager's role, and so I would feed back up to this, to the ECMG, and then sort of flow that information back as well in our COVID-19 emails that we did. Dr. Rob would provide us that specialist medical advice and particularly guidance around high-risk individuals. We leaned on Dr. Rob a lot during this period, and it was really good because it did support how we communicated to our team. My team became the COVID management team. And so working with Dr. Rob, we were able to develop those resources, but our pandemic managers were really important because we are dispersed geographically across New Zealand. And so...
Shelly, I've lost your voice. I wonder if you could turn your video off. I think you might have got limited bandwidth, please.
She's also accidentally muted herself.
Okay, so we've told you a lot about how we communicated, but we're a learning organisation. And so one of the really important things for us as we came up and out of COVID was to understand if we were doing it in the right way. So our communications team worked with our team and they pulled together a big survey in November 2021, and we had a good 30% of our people responded to that. And we asked them all about, we asked them how the emails were going. So, I think key to our communication response was the regular, almost daily at the beginning, emails. And what was really important is that those emails always came from me. And so there was that really consistent approach. And so people became really, they really trusted the way that we communicated with them. And there wasn't this kind of scattergun approach. And we did that right from the beginning, and it worked really well. So you can see there on the right-hand side of that slide that emails were the preferred method. But also it just highlighted how important those trust levels are with people managers, and that they could go to them with that information. And so that worked really well. And as you can see, we had 80% of our respondents rated the communications as good or excellent. So that was great. So we can just see that we have refinements rather than huge changes that we need to make. This is just a wee example, actually. I was playing around with my slides earlier and thought I'd move this around, but this just sort of shows our live intranet page, and it changed on a regular basis depending on the COVID-19 traffic guidelines and just what was going on. In the survey, actually, if you pop to the next slide, so you can see in the previous slide there were lots of resources, and we could update it really, really quickly. So in the survey that we had, the respondents sort of, it was a mixed bag really of how useful people found the intranet. But what we found as a team and managing the response is that having somewhere you could centralize everything, every time we sent out an email would pop that link in. So, people could use that quite quickly. Text alerts, they were useful, but people only want those for urgent messages and for time critical information. So we did try to use those a bit more at some point, and it kind of realized it actually should really only use those to push out those crucial comms. And we've talked about people leaders. And so just mindful of time, Rob, we can probably pop to the next slide and I can just do that wrap up of what we found.
Just one more minute. Sure.
Okay, we're going all right then. So effectiveness of future communications. Well, look, I think it was actually good news. The survey wasn't doom and gloom at all. What they wanted was less of stuff that they could see on the news and where they could read it in other media outlets, and to be more relevant to what would impact them in the workplace. So that was a good takeout. We obviously in the pandemic had different alert levels for different locations. So they wanted us to be really clear about how that would impact them for work. They didn't want their managers to duplicate. So just give them information that they didn't have rather than just repeating what was already put out in all of the Airways communications. And because we have people who work in towers and are not supposed to be on digital devices, they're supposed to be controlling the airspace, printable information that they can just access easily, so that's kind of the wrap up. So thank you very much for allowing me to talk about Airways response.
Thank you very much. Thank you, Shelly. And we'll move straight on to our next presenter, who is Catherine Epps, who hopefully has got her slides ready to share. Catherine is with Worksafe, and beg your pardon. Sorry, no, that's right. And she's leading Worksafe's response to COVID-19. So, Catherine.
Tēnā koutou katoa, ko ingarangi te whakapaparanga mai, ko bāf te whenua tupu, ko te whanganui a tāra te kāinga, E whakaere aho I mahu humaru e te roa, ko Catherine Epps aho, tēnā tātou katoa. Kia ora, it's fabulous to be here, and thank you, Rob, for the introduction. So I'm Catherine. I am one of the general managers at Worksafe, and I indeed led the COVID response on behalf of Worksafe. So it's great to be here and just to talk a little bit about those experiences. My background lies in understanding how work can be designed to reduce harm to our health from work, and even, we hope, promote good health, so that as workers we are all able to thrive as we come to work. Previously I've been worked clinically as a speech language therapist, specialising in returning people to work, particularly after traumatic brain injuries and other neurological concerns. All right. In this presentation, I'm going to aim to challenge common conceptions and just walk you through Worksafe's view of its role, helping businesses improve work-related health. So I'm going to go a little bit broader than COVID so that you can see how it fits in our broader work, and ultimately enhance your way of thinking about this important work. It's a great day that you're hosting today, Rob, so thank you. Look, our definitions are all available on the Worksafe website. You can see this in more depth if you're interested. How we work, where we work, and even when we work all have an impact on our health. Everything in the work environment has an impact. Many things you can see, hazardous substances, for example, many things that are harder to see. So mental health, the impact on our ability to be able to engage in work, or perhaps musculoskeletal issues, the harm that's done to our bodies over time. So businesses, as I think was already just mentioned earlier, businesses are required to take all reasonably practical steps to look after the health of their workers. There are many things to consider, though, within that work-related health environment to meet this requirement, COVID-19 and its effects being one of them. So it can be about providing the right equipment. It can be about reviewing shift work, for example, to make sure that patterns and rosters ensure that people remain in a mentally healthy state, and they're able to conduct their work and thrive as best they can in doing whatever work they do. So we're really focused on Worksafe on changing the dynamic about work-related health. So our intention is to work with businesses to change the rhetoric, the procedures, the thinking, because a lot of harm in this area is preventable if you can plan up front. And it's exactly the same with managing long COVID, to be able to talk about it, to be able to plan up front, to be able to risk assess the situation. So next slide, what's Worksafe's role? While our businesses are committed in New Zealand to looking after their workers, there is more that can be done to implement changes and shift our thinking about the effects of work on our health. And in fact, our performance is behind many other countries that we would normally compare ourselves to. So for this reason, Worksafe has made work-related health a real focus for us as an organisation, and we're committed to working with businesses to improve their understanding, to highlight new and emerging research, and to promote and share good practice in days like today. And so if we move on and just talk about COVID, next slide. For much of the COVID-19 experience for us all, then public health advice was our go-to place, and that obviously came from the Ministry of Health as our key kind of guiding star for how we approach the pandemic. The primary duty of care for workers sits with businesses or their organisation or employer that they work for. So while it might be difficult to determine if a COVID-19 infection happened in work or in the context of work where workers have been operating, in terms of any ongoing health effects, the employer needs to manage the risks arising from work, whatever they are. So as an example, at a high level, something that's relevant to us today is that a worker who has lingering fatigue, for example, from long COVID, may not be best suited for a role where long hours are needed, like driving long-haul transport vehicles, for example. And so there needs to be thinking done about what tasks they can do, which can balance, mitigate the risk, and consider all scenarios. So it's not possible to be prescriptive. I imagine there might be questions about, yeah, but what about my situation? It's not possible to be prescriptive in who needs to do what, but ultimately this needs to be businesses, workers need to talk together and work in good faith to find the solutions that work for their scenarios for their types of work. So next slide, what can you do? At its simplest level, supporting good work-related health is about listening to people, both health and safety reps and staff, about how best to conduct the role. People can give you the best insights into what is working, what's not working. While not everything, obviously, will that's ever raised will be able to be actioned, listening and hearing the voices of workers, they are the experts on the work they do, is the well-established good practice about finding a good way forward. The traditional pathways used more perhaps with safety are also relevant in relation to work-related health for this work. So risk assessments, making use of the hierarchy of controls, they're in all the safety textbooks, but have some relevance now too to how to manage long-term health needs in a workplace. You can also, of course, seek advice from others, some of whom are speaking today, so like occupational health professionals, relevant industry groups, even other businesses that have dealt with similar issues or have similar challenges. And yeah, if I go on to the next slide, I've also got a collection of resources. So we've kept our COVID-19 resources up on the Worksafe website. You are most welcome to go and source them there. And we also refer you through to a number of other partner agencies, because there are a number of useful resources and further information that you can find online. That's probably my speedy whiz through, Rob, in an attempt to get you back a little bit on time.
Thank you very much indeed. You do hang around for questions, because I'm sure that there'll be time for discussion at the panel. It gives me pleasure to introduce Paul Jarvie, who's the Manager for Employment Relations and Safety at the Employers and Manufacturers Association. So we'll talk to us about some of the employer responses. Paul, over to you.
Okay, so during COVID, obviously this happened quite quickly, and from an employer's perspective, work carries on and all employment law and health and safety law carries on at the same time. Next slide, please. So it was a very unsettling time, and really the government was kind of caught in a bit of a conundrum. Things were happening around the world and things were happening here. How do we react? And so what we saw was that the government was making policy on the run. And to be fair, we were part of that. So every morning we had meetings with the various ministers. They were looking at what they're going to do and how they're going to do it, and we'd try and put a business lens over that to ensure that it was business friendly as best it could be, and make sense of what was going on. Be fair to say that what ended up was a medical model rather than a business model in terms of response. And the medical model really was about to try and maintain the spread of the virus. So the plan was to minimize, isolate and segregate, and this was just buying time really for the vaccination process to be rolled out. Looking back, the health system couldn't have coped in any way, shape or form had we not isolated and we had lots and lots of people going to hospital. Equally, as part of that, as part of the plan was to provide economic security for those whose jobs were changed or lost, and these are these benefits and grants. And obviously there was a huge mandate to get vaccinated, which was part of the whole process. Next slide, please. So I think when you look back at what actually happened, companies were asked to create safety plans, and this was based on a health and safety response. So that was kind of normal language for businesses to do. How far they had to go was the real question. And what we found was that from a business perspective, because we were liaising with government, but then also talking to our thousands of members across the whole country, was there was large amounts of information out there. Some of it was really good, but we also had to deal with misinformation, disinformation, fake information, and that just created a whole lot of ambiguity and distrust really in the whole information train. Trying to get people back to work in bubbles, and how do you work in bubbles, how do you work in different shift patterns, minimizing contacts, isolation, all those things were kind of new language for returning to work and maintaining work. So it was really a really stressful time. When you're looking back, I think employers did a fairly good job at managing that change and rate of change. And we had this new concept of businesses pivoting and new ways of doing work. And they did that pretty well. And the thing about all this was working from home, it was introduced overnight. So the government says no more work, so we had to carry on work, so working at home. Next slide, please. When we look at how that actually happened, there was a huge amount of wraparound care. There was daily Zoom calls, there were Friday afternoon drinks calls, there was a lot of stuff going on to support people working from home. There was policies, procedures, there were planned and demand-driven contacts, support assistance. It was really, really good, and it was almost kind of a buzz. It became the thing to do. And I think from employers' perspective, they found that they could, in fact, trust their staff to work from home. Staff liked the flexibility and productivity was maintained. So overall, it was kind of a win-win situation. Next slide. What we have seen last year and continuing this year was that the amount of wraparound and pastoral care provided by business to people working from home has decreased. Connecting to people decreased. Staff were really left on their own, so it became business as usual to work at home, work as normal. There were no clear responsibilities whose job it was to make those connections. Expectations of work and workload were poor, and what we found were people were taking on more and more work. They were working longer and longer hours. And what we found, there was no social cues for starting and stopping work. When you're at work, if people get up and start going home, that's a cue for you to go home or take a break. And those social cues at work, you don't find at home. So the whole process and psychology of work changed. And what we found was that staff just ended up by doing more work, equally more work, more child minding duties of male and females, more house minding duties, a whole raft of stuff. And when do you stop work? And this is still a fairly major question. And really, I think what happened by default was working from home become business as usual without staff being in the office. This has led to the current research leading to isolation, depression, fatigue, and deleting contacts. Lessons learned. What we learned was that businesses can pivot when needed. So this happened literally overnight. So what we saw was businesses can get out there and pivot. Action plans from government were great, but there was no indication of exit strategies. There's no indications of when all these things were going to finish. So businesses like certainty, and that wasn't there. What we saw was that staff can be trusted to accommodate massive upheavals, and that was a huge learning curve for businesses, for managers, and for supervisors, and I think even though for staff. Mental health and hygiene must be ongoing for hybrid workers. So we're still seeing a lot of people working hybridly, either full-time hybridly or 3-and-2 kind of ratios. But what I've mentioned before, this lacking in terms of wraparound services. Public health strategies, e.g. from the Public Health Service and Ministry, can be deployed using Workplace, and we found that very, very effective. We ran hundreds of webinars to thousands of people to get the messages out there. I think when government is making policy, they need to use stakeholders, the major stakeholders like ourselves and unions, to get that message out there. So I think overall we've learned a lot, and we hope that those lessons remain learnt for anything that goes on in the future. Thank you.
Well, thank you. That's a great blueprint, I think, for employers who are looking to find solutions. Great talk. Thank you very much indeed. It gives me great pleasure to introduce Sarah Dalton, who's the Executive Director at ASMS, which is the Union for Senior Doctors and Dentists. So Sarah, welcome.
Kia ora koutou. Thank you very much for including me in this panel. I will keep my remarks brief, and there are links in my presentation, which I'm sure the organisers will share with anyone that is interested, including my email address. We are the Union for Senior Doctors and Dentists. So I'm using that lens to make my points, but a lot of them will hold for people who are not health workers, who are anyone who is a worker. But our membership has a particular profile. They tend to be type A, high achievers, hard workers. There is a culture of presenteeism in medicine. You often see it in education and across the health system as well, which means going to work when you're sick. A number of our members hold large job sizes and workloads larger than 1 FTE. That is not unusual. So they are some concerns and some issues and some context. On the plus side, our members enjoy excellent sick leave provisions and domestic leave provisions, which are not limited. So in general, people can take the leave they require when they require it. And since COVID, there has been some shift towards people actually taking leave when they're sick. Now that, of course, has added to issues of ingrained widespread short staffing and the culture of overwork that we see in our health system. So they are challenges for us. And while we know very little about long COVID, and this is a developing field, we do know quite a lot about fatigue, burnout, and unsafe work practices, which are ingrained across our hospital system, unfortunately, and many other workplaces. So the key thing here is decent engagement with and action from employers where there are known issues already. So whilst long COVID might not be the same as fatigue or burnout, there will be many symptoms and features in common with those things, which will impact on people's ability to participate in work. And I was really disappointed to hear from Worksafe an analysis that suggested that pretty much it falls on an individual worker's shoulders to manage themselves out of a job, which might have been their career and the thing that they are trained to do, if they no longer find themselves as able to perform that work as they were a year ago or 6 months ago or 2 years ago. And from our point of view, from the union's perspective, that is simply not good enough. This is part of our landscape. We need to support workers of all disabilities to participate fully in our workspaces. So if you're not hooked up with your union, I suggest you do join your union, talk to your union, because we are here advocating for you and pushing employers to do a lot better. We will be meeting with Te Whatu Ora to talk about their latest fatigue findings. Unfortunately, they've just found out the same stuff they knew before, and pushing them to do some real things to address those factors in tangible ways that will both prevent harm to workers and also enable workers who are already experiencing chronic illness or the outcome of accident or injury to work as much as they are capable and safely. So, for example, it is not uniform currently to feed staff who work overnight in our hospitals. It is not current practice to provide transport to and from or make sure people can access those. Large urban hospitals typically do not have childcare centres attached. We are not looking at those kinds of things that help people to work more safely. So I guess the challenge we need is both to provide safe workspaces that are going to prevent the spread of infection and disease. And in that regard, I do note the tendency to provide shared workspaces. People don't have an assigned workspace. You're supposed to share equipment, share spaces, which has proved a real challenge in a COVID context. So we need to move away to make sure that workspaces are large enough, well equipped enough. There is sufficient support for people to work safely who are not sick, and to be able to assume that you can probably go to work and come home safely and not infected. And then for those of you who unfortunately are experiencing any kind of a long-term condition, that we reimagine the way we work. The fact that if you can't manage a 40-hour week or a 10-hour week, there may well still be skills that you can bring in ways that you can work. And for many, of course, of our health and education workforce, remote work is not always an option. We need clinicians to be face-to-face with patients some of the time. And so there are real challenges there for employers, for the employers associations, for Worksafe to really do a lot better and partner with us. We know that you can trust working people. We know that workers do like to do the right thing. And the better we support our workers, the better off we will all be. Thank you so much for giving me some time to contribute. Ngā mihi ki koutou.
Thank you so much, Sarah. I think that we need some challenges, and you've given us something to live up to. That's brilliant. Moving on to our next speaker, and hopefully you can stay on for the panel session, Sarah. Moving on to our next speaker, who's Cathy Stephenson. He's from the Ministry of Social Development, and Cathy is she's the Principal Health Advisor at MSD, and she's going to talk about work and support for people who are working their way back to getting back to work. Thank you, Catherine.
Kia ora koutou, and thank you so much, Rob and the team, for inviting me here today. I'm the Principal Health Advisor at MSD and also a GP, and I've had to turn off my video because our clinic has appalling Wi-Fi and I don't think you'll be able to hear me, so my big apologies. But first, a wee bit about our mahi at the Ministry of Social Development. As many of you will know, we deliver a wide range of services to nearly every New Zealander at some point in their life, supporting them to be safe, strong and independent. We come into contact with young people, students, seniors, working age adults and their children through work and income benefits, sole parent support, study link, superannuation and other programs. And there is 250,000 tamariki whose mum, dad or caregiver depend on us for support. In terms of health stuff, we've got approximately 71,000 people with health issues who are reliant on the financial assistance provided through our job seekers support benefit, and a further 99,000 who are on supported living payment. Today, I'm just going to give you a real quick whistle-stop tour of the main ways that MSD can support people living with the ongoing effects of COVID. But first, I guess a few thoughts around why at MSD, and I think other agencies and organisations here today, why are we particularly interested and concerned about this group of New Zealanders? Well, I think firstly, we're concerned because we know from the numbers overseas that we're likely to see an increasing and significant proportion of our workforce affected by the ongoing effects of COVID. If we look at recent data from the UK National Office of Statistics, it shows us that working age people with long COVID are less likely to be participating in work than those who don't have long COVID. And this difference is most marked for those over 50 years of age. Estimates in the UK are that up to an extra 500,000 people may be out of the workforce due to a chronic health condition since the onset of COVID than prior to the pandemic. Now, this figure isn't going to be entirely made up of people with long COVID, but it does give you an idea of the problem that we may be facing in Aotearoa in the coming years. So here we've had 2.2 million cases to date, and although most people can expect to recover within 2 to 4 weeks, a significant number won't, and some will have persisting and impacting symptoms for far longer than 12 weeks. It's hard to estimate this figure here, but overseas data would suggest the percentage who are impacted by COVID in the longer term could be up to or over 30% of those infected. The risk of developing post-COVID-19 syndrome seems to be greatest in people over 50, those who have one or more chronic medical conditions or have a number of other risk factors, and many of MSD's clients will fall into this particular group. It's undisputed that being out of work has wide-ranging and significant negative effects, not only for the individual, but for whānau and community. It impacts on well-being, physical and mental health, financial security, and can, of course, lead to intergenerational effects and child poverty. So along with many of the other agencies represented here today, MSD has a huge vested interest in supporting people with long COVID to either remain in or move into employment. So what can MSD do to ensure that the right support is in place for the right client at the right time? Well, we'll start off with a quick look at job seeker support. So there's two kinds of job seeker support, the standard one and the one that relates to people with a health condition, injury or disability. This used to be called sickness benefit. So this one is for people of lower or no income who also have a short-term medical condition that impacts on their ability to work full-time. Eligibility for this is based on income and includes the income of others in the household. The client will need a medical certificate completed by their health provider, and once this has been supplied to MSD, a case manager will contact them and will then discuss appropriate supports, training courses, job opportunities, and explore any barriers that their long COVID may be creating for them coming back to work. The length of time that job seeker support can be provided is based on the clinical assessment of the doctor or nurse and can be revised if progress isn't as expected. So if someone with prolonged COVID is initially recommended to do no work for, say, the first 4 to 6 weeks, that can be revised up to part-time hours when their symptoms are improving. This benefit provides a really important opportunity for an individual to reduce their hours while still remaining employed. And we know from the recent US study by Brian et al. That indicates the sooner someone with prolonged COVID can get workplace modifications, and that includes reduced hours, and be engaged in rehabilitation, the more likely they are to return to work in the long term. Supported living payment is also an option. And this is an option if someone with prolonged COVID isn't going to be able to work more than 15 hours a week for 2 years or longer. It requires support and certification from the GP or a nurse again. And if the permanency of the long COVID is in doubt, it's actually better to use job seekers initially and then consider moving on to supported living payment later if improvement doesn't happen as expected. And I think for health providers, it's really important to remember that when recommending supported living and payment, we're effectively prescribing time off work for 2 years or longer. And sadly, research shows that a person on a long-term benefit like this is more likely to retire, age off benefit, or die than return to work in the future, with all the associated negative consequences on health and well-being that can follow. So a better option for patients with prolonged COVID might be a gradual return to work using job seeker support, as long as the right modifications and supports are in place. The next really common type of support we provide is disability allowance. Now, this is a weekly prorated payment that assists clients to meet health costs associated with prolonged COVID. So only a proportion of costs are covered, and it's up to a maximum of $70 a week. Again, the client needs to complete an application form, and a medical certificate is needed from their GP. So for someone with long COVID, the form might include costs such as appointments with their GP, transport to and from those appointments or to see another health provider, non-subsidised medications, the cost of engaging with a physiotherapist for rehabilitation, the cost of a gym membership if they're engaging in an exercise program, and sometimes things like the cost of someone doing your lawns or helping with your gardening. If the health costs are above the maximum $70 a week, a case manager can consider either temporary additional support or a special needs grant on top of this limit, depending on the circumstances. If someone is struggling with anxiety, low mood, or any other sort of mental health issues due to their long COVID, they can also ask their GP to fill in a disability allowance counselling form. This will fund an initial 10 sessions with a private counselling provider and a further 20 sessions if deemed necessary. And this amount is separate to the $70 per week available through standard disability allowance. Leave support scheme really pertains to acute COVID, and you probably all remember this one. It's available to employers and self-employed people to enable them to continue paying employees who need to self-isolate due to COVID-19 or are self-isolating to look after a household member. It's paid at a flat rate and there's no revenue test for this payment. So MSD has a really wide range of other programs and initiatives, too numerous to mention today. But when a client with long COVID approaches WINS, they will be offered a case manager whose role it is to ensure that they access the best supports at the right time. That case manager can connect them with a work broker, a training organisation, or an employment coordinator, and can ensure that employers know how to put the appropriate modifications and supports in place to enable someone to continue working, even if it's with reduced hours or other modifications and supports. There are also multiple specific programs and initiatives happening that the case manager can link them into, including options for voluntary or unpaid community work to gain experience, on-site industry training positions, which are funded by MSD for the first year, and flexi-wage support for people who might be interested in starting up their own business. So how can people with long COVID access these supports? Well, I think firstly, if you're a health provider or someone who's living with long COVID, the best place to go initially is our website. There's a huge amount of information on there, including the specific benefits, supports, and work programs I've talked about today. If you're an existing client and would like to access more support, call the helpline or visit your local office and ask to be assigned to a case manager if you don't already have one. They're the person who will be able to help you navigate the system. If you're a health provider, please contact your local MSD Health and Disability Coordinator. They're more than happy to discuss what supports and programs are available in your region and to ensure that the individual patients with long COVID that you're caring for are accessing everything possible to ensure they're on the best pathway to recovery. Thank you so much for your time today, and sorry that that was incredibly rushed and that you didn't have my video alongside it. Ngā mihi nui.
Thank you so much, Cathy. That was brilliant. Look, I'm sure there could be a lot of questions for all of our panelists, so I'm going to hand over to Rochelle, who's going to lead the panel session. We may get some time where we overrun into the lunch break, but I'm sure that you'll be agreed that these are important things to discuss. So, Rochelle, over to you.
Thank you, Rob. I was so busy sharing slides that I haven't spent a lot of time gathering the questions. So Rob, feel free to help me as we go along. But Cathy, there were some at the end that related to MSD. So one was related to why does MSD still have an income tested threshold for the disability allowance, with the comment that it excludes so many of us as the threshold is so low, it's an ableist policy. And the other one relates to, given that many doctors don't acknowledge long COVID as a reality, how does MSD deal with clients that can't get a medical certificate supporting their claim of long COVID? Have you got any thoughts that you want to offer about that at this stage? The
Yes,
other, Rob, sorry, I've just noticed, Rob, we were expecting Nick to speak.
Sorry.
Which would give me a little few more minutes to gather my thoughts
Nick,
about.
you're online. I beg your pardon. Sorry, you're muted, Nick.
Oh yeah, there we are, team. How are we? Kia ora koutou. My name's Nick Loveridge. I'm one of the docs working out of Taranaki in a rural setting in Taranaki. So I was just going to quickly share my screen with you here. Share. COVID Symposium. I was just going to run through a really quick case, just kind of highlighting the issues with regards to access in terms of management of long COVID, which kind of stem from mainly the barriers to care. So this is just a quick case that I was going to use to highlight it. So basically, 46-year-old guy who kind of presented normally very fit and well, very physically capable, who developed COVID in March last year, so during kind of the peak of the pandemic. And he had kind of moderate symptoms, managed at home, and 7 days unable to work, which was really tough on him and his whānau in terms of the workload that they had on the farm. He tried to return to work like most of the rural population would, very resilient and often are pretty kind of prioritised around their work obligations and that kind of side of things. And so kind of considering their health as a secondary priority. He presented 4 weeks later to the GP, just unable to complete a full day of work. And like probably most of us are aware of, he had a very kind of broad ranging and diffuse set of symptoms, which included lethargy, reduced exercise capacity, muscle weakness, shortness of breath, nausea, exacerbations with physical exertion. And he said that he'd just fluctuate day to day. And it would be over the period of a day, he'd have normal energy and kind of fluctuating to being really weak. He had a really wide kind of range, and this is kind of some of the symptoms that we've been experiencing. And yeah, so the features that were quite unique in the kind of rural setting. There's a few different features that are particularly unique in the rural setting, which kind of are features common to a lot of long-term condition management in rural environments. There are some that are very unique to conditions such as long COVID. And from experience, we're talking about things like denial that symptoms are attributed to a specific condition. And also the stigma of kind of both post-viral syndromes and also syndromes or symptoms that don't have very clear evidence of etiology. For example, not injuries or not very clear kind of things that people can fall back on. Then access to care is the kind of the next kind of thing that starts playing a really unique role in a rural setting. Now, that's mixed up between patients' work obligations and, kind of around lack of support within a rural environment, especially where, the communities are very supportive, but often the workload is very difficult to find long-term cover for. And then there's the medical barriers, and these are not small. We know that there's significant under-resourcing in terms of general practice and primary care in a lot of rural environments. A lot of patients can't get in at the best of times. And for conditions that are long-term that require multiple interactions with the general practitioner, there's often a lot of delays in terms of both accessing the general practitioner in the first place and then subsequently beyond that accessing the appropriate investigations. And then within the rural setting, there's also a lack of access to multidisciplinary teams and also specialist knowledge that you might find in urban settings. So it's often down to the diagnostic expertise of the GPs, which is often, often very capable GPs in rural settings, but it's one of those ones in which the specialist knowledge is often lacking there. So the diagnosis in this bloke's case took a very long time, and this is pretty classic of it. He comes in with some symptoms, investigations go off, they take a bit of a delay in getting back, then it takes him a long time to get back in. And it must have been 6 to 9 months before he was in a position in which we were starting to rule out almost everything that needed to be ruled out to confirm a diagnosis of this being, no other pathology that could be responsible for this. So the next thing is managing it. And this is kind of follows the same lines where in a rural environment, we've got a lot more barriers to accessing care than we do in an urban setting. So the patient kind of side of things, again, that rural resilience and she'll be right attitude is kind of prevalent. And it means that a lot of people put up with symptoms for far longer than they would do in an urban setting. And there's a far higher threshold for seeking medical intervention. The responsibility of working with lack of cover in an unsupported and isolated rural setting then comes into this. And when we look at the management of conditions like long COVID, that is one of those ones in which that lack of ability to facilitate kind of supported recovery can have long-term implications for these patients. And then cost. It was nice to hear, from Michelle talking about kind of wins-based costing, but these guys are often people who have huge loans and huge financial obligations. And it's often their own property or a family run farms, that kind of side of things, in which they need to maintain income. So they're pressured back into getting back into work probably before they should and doing more work than they should. And then it's kind of backed up on top of that in terms of the access to appropriate investigations of management with the lack of support in that space. When you look at this is the health pathways guidelines on the right hand side here, and it's talking about access to dietitians, occupational therapists, physiotherapists, speech and language and psychology. And we don't have access to any of that where we are. That would mean somebody traveling or somebody engaging in virtual care, and that's all going to be funded privately unless they meet the WINS criteria. So that does become very expensive, and it's often declined through the secondary system. And in terms of medical factors, is obviously there's in terms of accessing those kind of specialist services and allied health teams, it's just not able to be done sometimes in the rural setting. Then kind of that becomes something that falls back on the primary care provider. So in terms of the other kind of area in this is the community and the employer. Often in these settings, often the employer has the same stigma and the same misunderstandings of these long-term conditions as the patient does. And so we often end up in a bit of a position where we're trying to establish just why the patient needs so much time or so much support to get them back to work and to get them healthy again. And it's often takes quite a lot of discussion and quite a lot of education around with not just the patient, but also with the employer to facilitate that. And that often is something that's really difficult to get that time to sit down with everybody involved in these cases to really to work together to get the best outcomes for the patient and the employer. So this bloke would have taken him, like we're saying, about 6 months before he got to the position in which he accepted his diagnosis and where he was going to go with it. And it took him, he's now, looking at being 12 months nearly now, and he's still not working full time. He's needing support. He's lucky he's got some family in the local area that are supporting him with his herd, but it is one of those ones in which he is a pretty unique in a pretty unique position. So basically, brief takeaways, I think, in terms of the rural setting, is that there are increased barriers to care from both diagnosis and management, and it is a really difficult one to get around with very few options. This is not just limited to long COVID, and it can be any other long-term condition as well. and it is one in which having a strong relationship with the primary care provider between the patient and the primary care provider and the community is really critical to overcoming this and making the most of the resources that are available. So yeah, thank you very much. And I think it was probably relatively brief, but if anybody has any questions, happy to answer them.
Thank you. Look, we'll have a panel session now. And Cathy, you've seen some of the questions in the Q&A box. So perhaps do you want to address some of those proactively?
Absolutely. Rob, please let me know if my sound is not okay, because I've kept my video on, but it might still be really glitchy. I'm just going to start at the bottom. One person, Gillian, I think, has said GPs are reluctant to say long COVID will last 2 years, which then impacts access to benefits. The wording for our supported living payment, which is the benefit for a longer term health condition, is that the condition needs to be proven to be permanent and severe. So obviously the problem, if you think about Nick's case he's just talked about, is actually for the first few months, many people will improve to the level that they can go back to work part-time, which is far better in the long run for them and their whānau and community in terms of earning income, but also in terms of the health and wellbeing impact. So the reason that we often won't say initially something is 2 years is because we genuinely don't know somebody's prognosis. So I think once it's clear that progress has become static and that work is really only going to be under 15 hours, then at that stage we could say, yeah, look, it's likely that for 2 years or longer, this person is going to be limited to less than 15 hours of work a week. But until that point, we actually can't apply supported living payment. So I hope that kind of answers that question. The next one was around the approach towards applying disability support appears to be very varied between doctors rather than being based on patient symptoms. Is there a way to address this? I mean, we are very much guided by the health provider's opinion on work capacity, and that's how we make the decision at our end. But our health and disability advisor teams are available in every region, and it's their role to kind of be the connector between the health provider and the case manager and the client, and then us who are often making the decisions up at MSD as well. So if there is a concern that a client or patient is feeling their needs aren't being met, they're not being heard, we have an opportunity to get a second opinion through something called our designated doctor process. And the case manager can absolutely talk to the regional health teams who can come back to us and say, look, it appears that this doctor isn't enabling the patient or client to get everything they're eligible for, and then we can have a conversation at that point. So there are lots of ways we can address that variability. Rob, I don't know if there's time for me to do any more or whether you want to open it up to everybody else.
I had a question really for the union representatives here today, and in response to questions that have come up. I'm just wondering if you've got any thoughts about what ideal internal policy responses could be within workplaces and organisations, given a reducing national sort of national mandates or strong government recommendations about keeping people safe at work and supporting people to return to work safely and sustainably after COVID or when experiencing long COVID. Have you got any thoughts about what might be these ideal internal policy and process responses within organisations?
Rochelle, is that for me?
Anyone can answer that. You, Sarah, particularly, or Paul?
I'm a little bit off policy responses because they are often really, really blind to the actual needs of working people. So while the unions would like to see, really good sick leave policy. So one of the reasons I mentioned senior doctors' sick leave in their collective agreement is that it's an as-needed provision, but many workers don't enjoy an as-needed sick and domestic leave provision. So let's put that in there. Let's make sure that we staff sufficiently so that there is flex, that when you expect more people might need time away or that they may have to work shorter hours, the burden doesn't fall on your other colleagues who are left behind, because that creates resentment. And that's what we unfortunately see already, that for someone who is unwell long term, they will be supported up to a point, and then when they fail to get better, they will be shuffled and pushed and encouraged to move out, because at the end the employer's response is to say, well, your disability is your problem. So we have got lots of education to do about that. But yeah, I mean, just making up policies doesn't actually tend to help workers that much. what helps working people is to have really strong employment provisions that are supportive of them being able to take the leave they need when they need it, and know that their colleagues are not going to be overly burdened as a result. And that's what we'll continue to work very hard to support.
Thank you, Sarah. And Paul, is there anything, just as a last comment before we break for lunch, is there anything you'd like to add to that?
Yeah, just really the kind of the principle that just because someone's sick, irrespective of what the illness is, employment law and all the other laws are still active. So while it's very good to talk about having extra this, extra that, extra all these other things, at the end of the day, the employer's got to pay for it. So someone's got to be earning the money to pay for all these other bits and pieces. And that's the kind of balance that employers have to try and maintain. And that's not dissimilar from someone who's had a broken leg that's now become septic and they've had operations. Eventually there's a time he says, well, we've accommodated long enough. We have to call halt because I need to keep my business running. And it's where you draw that line. Because we see the same kind of issues with well-being and mental health issues. They're out there everywhere, but a workplace is a workplace and it's governed by law. And the laws are very, very black and white. And some of the things, if employers accommodate for long periods of time and then decide, well, I can't do it anymore, the fact that they've accommodated for a long time actually works against them. So it's a real balancing act. I totally agree. It's about communications and working with employees, working with the medical profession and all the other providers. But it's got to be an open and transparent communication to get that right dialogue, to have the right plan. Thank you.
Fantastic. Thank you, Paul. Rob, I'll hand back to you.
Thank you. Look, thank you, everybody. This has been a very interesting session, and I'm sure that there'll be more discussion, which you may want to do direct with the presenter. I think it was really important that we actually had the panel session, so I'm afraid we're going to cut our lunch break a bit shorter. So we'll give you 20 minutes to grab something to eat and be back at 1 o'clock. Thanks, everybody.